In 2026, the National Health Service commands a revenue budget exceeding £200 billion. It is one of the largest public enterprises on Earth, built on a statutory promise of universal, comprehensive care. But the financial scale masks a systemic collapse. As the budget climbed past that $200 billion mark, public satisfaction plummeted to a record low of just 20%. This failure has forced 4.7 million people to rely on employer-provided private medical insurance. This coverage is now a standard requirement for high-paid technical workers who need a way to bypass record-breaking waiting lists. For essential non-technical workers, cleaners, porters, and care staff, this escape hatch does not exist. They remain stranded in the public system, creating a two-tier healthcare reality based on occupational status. Since 2012, the government has managed the NHS and the welfare state as a portfolio of corporate assets. Policy has prioritized relentless organizational restructuring over the historic duty to protect the health of the people. A decade of this corporate-style reorganization has engineered an accountability gap. The state holds immense power over these services, yet it has removed the legal frameworks that once held ministers responsible when citizens are harmed. The 2012 Health and Social Care Act imported a market-driven logic into the boardroom. It fundamentally altered how hospital executives are incentivized to behave. Under this system, hospital trusts are ranked on league tables. They are judged on financial performance and waiting time metrics, rather than the quality of the long-term patient experience. The stakes are purely transactional. High-scoring executives gain financial freedoms and autonomy. Weak performers face central sanctions and the loss of local control. This was evident at T's Esk and Wear Valleys Trust. Management prioritized finance buyouts and divesting GP contracts to meet targets. These maneuvers fragmented care. Families described unclear leadership and failing follow-ups, a governance void where adolescent patients lost contact with clinicians, causing preventable deaths. League tables measure executive compliance, not patient safety. They reward the achievement of a numerical target, while obscuring the systemic fragmentation that puts lives at risk. These lethal errors are supposed to be caught by the parliamentary oversight mechanisms tasked with scrutinizing the executive. When safety incidents occur, independent inquiries are launched to establish facts and mandate changes, like the Robert Francis Review into the failures at Mid Staffordshire. But the Health and Social Care Committee's expert panel found a critical flaw in this process. The government often accepts these safety recommendations on paper, but has no formal mechanism to track if they are ever implemented in practice. Safety warnings are frequently lost within an uncoordinated bureaucratic space, acknowledged by ministers, but never followed through to the point of clinical delivery. Without an enforceable tracking mechanism, parliamentary scrutiny is toothless. Oversight becomes a ritual of documenting tragedies rather than a tool for preventing them. This same logic of administrative distance governs the Department for Work and Pensions, driving welfare redesigns like the two-child limit. These changes have expanded the gap between state decision-makers and the families they affect, reducing the visibility of child hardship. In Belfast, this system created a prolonged processing blockage for a citizen entitled to support. Despite explicit warnings that the individual was at risk of collapse, the administrative machinery failed to act. The system brought that person to the edge of starvation before the error was finally corrected. It proved that the machinery of the state can inflict acute physical harm long before a safeguarding alert is triggered. To address these delivery failures, the government is now proposing the abolition of NHS England, centralizing its functions directly within the Department of Health and Social Care. This centralization removes the operational independence that previously allowed for external scrutiny. It disbands patient voice mechanisms like HealthWatch, stripping away the public's ability to provide direct feedback. Consolidating power without restoring a clear duty of care transforms the government into an entity that monitors its own performance, while citizens continue to absorb the consequences of its errors. The current architecture is broken. We have a welfare system creating administrative harm, a health system fractured by corporate logic, and a government failing to use the intervention powers it already possesses. Before any further restructuring proceeds, Parliament must implement a mandatory legal check, the Constitutional Impact Assessment. The CIA requires defining a statutory chain of command. It identifies which official holds the duty of care and is legally responsible if a citizen is harmed. Mapping these duty holders ensures a clear, enforceable escalation pathway whenever a service fails. The NHS and the welfare system are not commercial subsidiaries. They cannot be managed through the lens of executive league tables. These services represent the fundamental duties of protection that the state owes to its citizens. Until the constitutional impact of these reforms is measured and published, the state will continue to legislate in the dark. And the most vulnerable will continue to fall through the cracks of a broken architecture.